Welcome to this presentation entitled Current Concepts in Ultrasound. My name's Stephen Bird, and please visit my website birdultrasound.com.au to enjoy more educational material. In this presentation, I'm going to delve into some fresh ideas and concepts that have changed the way I perform my musculoskeletal ultrasound in a variety of body areas. The first area I'm going to consider is the foot and ankle. And what I'm doing now is I'm dorsiflexing and plantarflexing this foot, and then I'm performing like an internal-external rotation of the foot. During dorsiflexion and plantarflexion, what I'm using now is this blue joint here, which is the ankle joint. And then during the scissoring action from side to side, I'm using the subtalar joint. Now, when we perform an ankle ultrasound, I think we're very good at looking at the ankle joint capsule itself, but I think we need to pay more attention to the subtalar joint, as this is very commonly a driver for the patient's pain. This is an example of an anterior ankle joint capsule, and you can see how thick the joint capsule is and how synovially proliferative it is. And with the Doppler algorithm, we can see how hypervascular it is. And this is a classic case of ankle joint synovitis, and this is the direct cause of the patient's symptomatic pain. Sometimes we can see the reason for the synovitis, and this is an example of anterior impingement. If you look at this schematic, there's a little spur here on the tibia and another little spur here on the talus. And as we move the ankle, this causes an impingement. So if you look at this ultrasound image, we can see there is in fact the little spur coming there, right there from the tibia, and here's the corresponding spur right here on the talus. And we can see how thick this anterior joint capsule is. So this is an example of anterior impingement leading to synovitis. When we do a look at the joint, you can really see these two spurs, and then we can see how thick the joint capsule is. Of course, a normal joint capsule is so thin we can hardly see it. We just see this normal fat tissue sitting in front of the capsule, and the joint capsule is a very, very thin hypoechoic line, but you can see here it's very thickened. How do we find the subtalar joint? So the subtalar joint is here, and what I do is I follow the peroneal tendons down around the corner. I go past the superior peroneal retinaculum, and then when I arrive and I see the calcaneo-fibular ligament passing underneath it, I look just anterior to the peroneal tendons, and I see a little crack, a little articulation, and this is the subtalar joint. So if you watch the ultrasound video here, you can see there's the peroneal tendons. That's the CFL ligament going underneath, and there's the little crack in the bone. This is the calcaneum, and this is the sinus tarsi, and that is the subtalar joint effusion coming into the sinus tarsi. So we've got calcaneum, we've got talus, that's the subtalar articulation, sinus tarsi, and there's the small effusion. And so this is the area here where we're seeing the small effusion on an MRI. So when I come down into a subtalar joint, again following the peroneal tendons down, past the CFL, and now arriving at the articulation, you can see here that there's a joint effusion. So I know I've got a subtalar joint effusion, and then when I drop into the sinus tarsi, which I am now, you can see this effusion is a reasonable size. So when I'm looking at a sinus tarsi, I'm looking for fluid. If it's a monoloculated, compressible puddle of fluid, then this is an effusion. If it's multiloculated and non-compressible, it's a ganglion. And in this case, you can see that it's not really fluid, but just a lot of synovial proliferation sitting in that area in the sinus tarsi, just as you've dropped into the sinus tarsi from the subtalar joint. And this is an area of synovitis. So at the level of the joint here, you can see that the joint capsule is quite thick and distended, not really an effusion so much as synovial proliferation. And when we put the SMI on it, this is very vascular, and then in the sinus tarsi, rather than fluid here, we see synovial proliferation, and then with the Doppler, we can see how vascular this is, and this is a subtalar joint synovitis that's expressing itself as hypervascularity and synovial proliferation in the sinus tarsi. We can also look at the subtalar joint from a posterior approach. So what I've done now is I've laid the patient prone, and then I bring the transducer in just slightly lateral to the Achilles tendon, and I angle it back towards the midline in the sagittal plane, and I see three bones. I see the tibia, the talus, and the calcaneum. Now, of course, the subtalar joint is the articulation between the talus and the calcaneum, and you can see there's a large effusion coming out of this subtalar joint. So this posterior approach works really well when you're looking for an effusion, and also works really well if you're looking for synovitis. In this position, we can also do some dynamic assessment. So although the patient's prone when we're scanning, we can still do the same movements with the foot. And as we do the dorsiflexion and plantar flexion movement, that will move this articulation here. So this is dorsiflexion and plantar flexion coming up now, and that's the ankle joint moving. And then when we do the side-to-side scissoring action, which we're doing here now, that's the subtalar joint moving. So when we're assessing for the posterior part of the ankle, we can have a look at the calcaneo-fibular ligament, we can look at the posterior talofibular ligament, and we can look at the intermalleolar ligament that goes between the fibula and the tibia. So this, if you like, is the posterior inferior tibiofibular syndesmosis. And if the transducer is at this angle here, pointing towards the apex of the calcaneum, this will line up on the CFL. If the transducer is fairly axial, this is the posterior talofibular ligament, and then the intermalleolar ligament, you need to steeply angle up towards the tibia. So this is the CFL here. This is the posterior talofibular ligament here, and you can see that's fairly horizontal, and this is the intermalleolar ligament here. So if we scan through, this is the calcaneo-fibular ligament here, and you can see the peroneal tendons are sitting on top of it. So this is perfectly lined up with the calcaneo-fibular ligament. And then as we rotate around 90 degrees, this is the CFL in its short axis. And then slightly above that, this is the posterior talofibular ligament. And you can see the posterior talofibular ligament is a very, very thick ligament. It has this large triangular shape, as you can see just here in the video. And then as we then swing the transducer around, keeping on the fibula here and angling the transducer up towards the tibia quite steeply, this is the intermalleolar ligament. So this is the posterior inferior tibiofibular syndesmosis. So sonographically, I think we can assess the calcaneo-fibular ligament, which we can see beautifully there on that image, in its long axis, and now you can see it in its short axis. And then we can swing from that more horizontally. That's the posterior talofibular ligament there, and then swing the tibial end of the transducer more northwards into the intermalleolar ligament, and it's beautifully seen there. So when we're looking in this posterior ankle joint, you can see here that in the actual area of the posterior ankle joint, it looks quite thickened. And then when we put the Doppler on it, it's quite vascular. So this is a posterior ankle synovitis, and this is part of a posterior impingement syndrome complex. You can get posterior impingement for a variety of reasons, and two of the common reasons would be, first of all, having a large os trigonum, and the second would be having a stiter process, which is an elongated posterior process on the back of the talus. So this is an example here where we have either a large os trigonum or it may be a long stiter process here. But either way, this posterior ankle joint is very crowded, and then we can see that the synovitis develops in this area, and this is posterior impingement on an MRI scan. This is posterior impingement on an ultrasound. So you can see how thick and craggy this posterior ankle joint capsule is. It's very, very thickened. And then using the SMI, it's really hypervascular. So this is a classic posterior impingement. And of course, you've got the patient prone. That's the tibia. This bone here is the talus. And then this is the calcaneum. And you can either do dorsiflexion and plantar flexion will move the ankle joint. And that's what I'm doing here. If you do the scissoring motion, this joint here will move. And that's the subtalar joint. So more examples, and you can see how you can use the dynamics, and you can see the thick capsule, and then you use the Doppler to see the synovitis. And this is really a nodular synovitic change that you get in the posterior ankle joint. This one's affecting the subtalar joint. So you can see it's more centered over the talus and the calcaneum here, but it has a very similar appearance. So rather than being here in the ankle joint, now we're here in the posterior subtalar joint. The joint capsule's very thick, and using the Doppler, you can see how vascular it is. And this is posterior impingement of the posterior subtalar joint. The next concept that I want to introduce is the concept of the lines of weakness inside the ankle and foot apparatus. So the first, the foot is a very French place with names like Chopart, Lisfranc, and Charcot, which of course are all French words. Now, first of all, the Chopart line is this line here, and this is the line between the hindfoot and the midfoot. So it's the line between the talus and the calcaneum, and then the navicular and the cuboid here. So this is a natural line of weakness through the foot, and then there's a second natural line of weakness, which is the Lisfranc line, which is between the midfoot and the forefoot. So when we have an an inversion injury to the ankle when we have a traumatic event to the ankle joint. If the anterior talofibular ligament and the calcaneo-fibular ligament and the syndesmosis here survive that injury, sometimes the trauma will disrupt through this Chopart line. And this is a really common pattern, and it's really nice to understand with patients that have had inversion injuries. Of course, a Charcot foot is the diabetic neuropathic foot, where we get a crumbling of the articulations here in the midfoot. Here it is on a lateral radiograph of the foot, and you can see these two natural lines of weakness. The first one is the Chopart line, and this is the one we're going to concentrate on today. And you can see how it very much is a natural line of weakness through the foot there. And then, of course, the Lisfranc line runs through here. So if we are assessing the Chopart line, I like to start at the dorsal talonavicular ligament, because I like to look at the ankle joint first to see if there's a joint effusion or a hemarthrosis, and then I simply slide the transducer down the midfoot until I rest it over the distal talus and the navicular bone. So this is the talus and this is the navicular, and you can see this is where the dorsal talonavicular ligament should be, but in this case there's been an avulsion fracture, and you can see this piece has been pulled off of the navicular bone, and when we blow up the radiograph you can see that this is the avulsion fracture here, and this avulsion fracture of course is in the Chopart line, so we need to then consider that other ligaments in the Chopart line will also be affected by this trauma. And the next ligament that I like to consider in the Chopart line is what some people refer to as the bifurcate ligament because of this V-shaped arrangement. But the part that I look at is this part here, which is the Calcaneo-Cuboid ligament. And in particular, I'm interested in this part here, where it has its origin from the anterior tubercle of the calcaneum. So this is the calcaneum, and this is the cuboid bone. This is the lateral talar artery that sits here, and this is the long, slender ligament that runs across here, across the articulation. And where it fails is here. And when it fails, it very commonly takes a fracture from this anterior tubercle of the calcaneum, and this is very difficult to see on a plain radiograph. Of course, when you have a fracture here, then you very commonly have concurrently a dorsal talonavicular injury at the same time, because of course this is that Chopart line through the foot. So this is what my patient presents with. They present with a bruised, swollen ankle, and it's this bruise pattern that's quite typical. And when I assess the anterior talofibular ligament, which is here, and the calcaneo-fibular ligament, I may or may not find any injury. But when I then come down to the calcaneo-cuboid, and this is the calcaneum and this is the cuboid, you'll see that there is a significant injury, and you can see that there is a large avulsion fracture that's been tugged off. Here it is here, and this is what's bled out and caused all of this bruising in the foot, and I'll show you some more examples. So in all of the examples you'll see that the cuboid is relatively well preserved, so the cuboid looks fine, but the anterior tubercle of the calcaneum has been disrupted, and it's this classic avulsion fracture that we're looking for. Here's another example, and it's that bruise pattern that alerts me to the fact that we're going to have something significant in this foot, because of course these avulsion fractures are quite large. You take a large piece of bone off of the calcaneum when the anterior tubercle is disrupted, and this bleeds extensively, causing these large bruises. So this is what happens with a Chopart line failure, is you have a dorsal talonavicular ligament. This is the comparative normal side, and then this is the symptomatic side. So you can see that the symptomatic side, the talonavicular ligament, does not really have any avulsion fracture, but it clearly has been damaged. It's very thickened, and you can see on the video clip here how thick it is. And now we're coming back over to the calcaneo-cuboid, and you can see there's the avulsion fracture. So this is the extensor digitorum brevis muscle on the top, and you could see that avulsion fracture, and now I'm sliding across the foot, across the Chopart line, and you can see the dorsal talonavicular has this swollen hypoechoic architecture. So there has been stress right across the Chopart line. We've got a complete failure and avulsion of the calcaneo-cuboid ligament, and then we've got an injury, a significant strain injury to the dorsal talonavicular. Another piece of anatomy that's very, very close here is this muscle belly here, which is extensor digitorum brevis. And extensor digitorum brevis, so this is it here, and this is it here underneath the extensor digitorum longus. This muscle has its origin in this area here. So it attaches onto the calcaneum just ever so proximal to the origin of the calcaneo-cuboid ligament. And another thing that attaches on here are parts of the extensor retinaculum that run through this area here, which is the sinus tarsi, and we'll touch on those as well. So this is a very busy area of the foot. we can not only see injuries to the Chopart line and Calcaneo-Cuboid injuries, but also we can have injuries of the extensor digitorum brevis origin and the extensor retinaculum as well. Let's have a look at some examples. So this is an example. The muscle that sits on top of your calcaneo-cuboid ligament is always extensor digitorum brevis. In fact, it's the only muscle on the dorsum of the foot, with the most medial slip of it being given the name the extensor hallucis brevis, but it's all the same muscle. And you can see here how disrupted this muscle is, and you can see all this periosteal lifting here, this echogenic periosteal stripping, where extensor digitorum brevis has been stripped away. The calcaneo-cuboid ligament is normal, and the anterior tubercle of the calcaneum is preserved here, and this is a muscle origin injury rather than a CC ligament injury. On the still images, you can see that beautiful periosteal stripping, and this is a really characteristic finding. General disorganization of the muscle, and when you compare it to the other side, you can see it's a very striking difference between the two sides. So this leads me to the sinus tarsi, and you might have just thought of the sinus tarsi as just being a nice triangular puddle of fat, if you like, but there's more to it than that. If you look at the way the extensor retinaculum works on the foot, you can see that these bands of the extensor retinaculum come from the calcaneum and they wrap around extensor digitorum longus, and then they come back and they go underneath extensor digitorum longus to attach onto the calcaneum here. And these bands, this one here, the medial root of the lateral calcaneum component, and this one here, the medial root of the medial calcaneal component, these can be implicated with traumatic events of the foot, and we can see these nicely with ultrasound. You can see here on the ultrasound picture, these are the structures here that we're seeing coming across. And this is the transducer position that we use for having a look at the sinus tarsi. So first of all, the anatomy. This is the extensor digitorum longus, and you can see the way that these bands of collagen come and they come across and they attach here onto the calcaneum. The muscle on top is the extensor digitorum brevis muscle, of course, and that's attaching more here. But these bands of collagen attach onto the calcaneum here, and you can see here there's been some traction enthesopathy due to chronic traction of this ligamentous apparatus. So here's another nice example, and in this case you can see it's pathological. This is the other foot, so it's the other side, and you can see how here the medial root of the lateral calcaneal component has been damaged. And so you can see it's thickened, hypoechoic, and has multiple areas of cystic change inside it. So this is an acute traumatic injury of the extensor retinaculum apparatus within the sinus tarsi, and this is where the patient was point tender on examination clinically. So we can see in this video how in the short axis and in the long axis we can assess this structure. So that there it is in the long axis, and then I'm going to spin around for you and we'll have a look at it in the short axis as well. There it is there, and you can see how this really nicely shows the sort of cystic degenerative change that we're seeing after the traumatic event. Of course, the surrounding area, all the fat of the sinus tarsi surrounds it. We can then look at it with a color Doppler algorithm. This is advanced dynamic flow, and you can see how it becomes hypervascular as well as part of that injury and then healing process. Another thing on the lateral side of the ankle I want to touch on is the peroneal tendons, because when I look at the peroneal tendons, I don't like to think in terms of simple peroneal tenosynovitis. I think there's always a cause for peroneal tenosynovitis, and I think the cause is quite predictable. If Peroneus brevis is involved, this is implicated because Peroneus longus gives a compressive injury to Peroneus brevis as it goes around that lateral malleolus deep to the superior peroneal retinaculum in this area here. If Peroneus longus is involved in the disease process, then this is nearly always because of at this inferior peroneal retinaculum level, a peroneal tubercle syndrome. So peroneal tubercle syndrome attacks Peroneus longus, and compressive events attack Peroneus brevis. So with peroneal tubercle syndrome, it's here at the level of the inferior peroneal retinaculum, and it's when most commonly you have a large hypertrophic peroneal tubercle, and you can see Peroneus brevis is quite happy here. Peroneus longus is very thickened, hypoechoic, hypervascular, and the retinaculum over Peroneus longus is hypertrophic. This is classic hypertrophic peroneal tubercle syndrome. Sometimes it's very obvious what's going on, and you can see this peroneal tubercle is really large, almost like the Eiffel Tower coming out, and then Peroneus longus also has some calcification within it. So this is a very difficult situation for Peroneus longus. It's got a very thick retinaculum, the tendon's very swollen, we have a very large tubercle, and then we have this calcification also inside Peroneus longus, and this is going to be very painful for the patient. This is a great example of Peroneus longus tendinosis, and you can see how tendinopathic it is because it has this spotty appearance. So instead of linear lines like in the Peroneus brevis here, this has been replaced by this particle board or spotty type appearance, and this is classic for tendinosis. And the cause of this in this case is this peroneal tubercle. So you can see the peroneal tubercle is quite large, and it has a very thick retinaculum over the top, and also the surface contour of the peroneal tubercle is quite irregular and rough. So this is what's disturbing and causing this Peroneus longus to become tendinopathic. I used to always think that you needed to have a big peroneal tubercle to have peroneal tubercle syndrome, until I see cases like this. So in this case, Peroneus longus has a tenosynovitis. You can see the fluid around the tendon in the sheath, and you can see the hypoechoic change in the collagen of the tendon itself. But where's the peroneal tubercle? There is no peroneal tubercle here at all. It's completely absent. But regardless of the absence of the peroneal tubercle, we still have a very thick inferior peroneal retinaculum, and you can see it here. So you still have a stenosing tenosynovitis of Peroneus longus here, even in the absence of a peroneal tubercle. Sometimes it's just the anatomy of the tubercle that's a bit unusual, and in this case, this is actually the peroneal tubercle over here, but you can see there's another accessory peroneal tubercle sitting over here, and this is actually digging into Peroneus longus, and you can see the way that it's trying to split it in half as it tries to move over the top of it there. So this is just, you can see as I'm pressing there how it's really distorting Peroneus longus, and this is just an unfortunate piece of anatomy. The next thing I want to touch on is the biceps brachii. So we're moving to the elbow now. And the reason I'm interested in this area is because I have patients where I see some tendinosis of the biceps brachii apparatus. So you can see there is some fluid in the bicipital-radial bursa, and there's some thickening of the distal biceps brachii, and you can see it in the short axis and you can see it in the long axis. So we have biceps brachii tendinosis, but the patient doesn't have any history of any heavy work or trauma that's led to this. And in fact, using the advanced dynamic flow here, you can see how hypervascular that biceps brachii is. And this is using the pronator teres window. So this is the pronator teres. So it's using a very medial approach to get these lovely pictures. And you can do that in the long axis like here, and you can also do it in the short axis here. So the question is, why has this person got a biceps brachii tendinosis? And this is the answer, is some people anatomically have quite a tight gap between the radial tuberosity, which is of course the distal insertion, the bony landmark that the biceps brachii inserts onto, and the corresponding ulna. And in this case, what I'm using now is I'm using the cobra type technique with the elbow flex and the hand pointing towards you, and I'm scanning in through the back of the elbow here. So this is the ulna, and this is the radial tuberosity. This is the anconeus muscle at the back here, and you can see there's quite a nice gap here, but on the symptomatic side the gap is very tight, so the biceps brachii apparatus gets caught in an impingement. So it's an impingement of the biceps brachii between the radial tuberosity and the adjacent ulna, and what this leads to is it leads to tendinosis and eventually tearing of the biceps brachii. And you can see this is the normal side, there's lots of room here, and this is the abnormal side, and you can see how tight it is. So these patients will present with biceps brachii pathology, as this patient has, and then when you put them through a dynamic maneuver, and the way I'm doing this one is having the patient scanning from the pronator teres window, so scanning from the anteromedial approach in the transverse plane. This is the ulna, this is the radius, and then I'm doing internal and external rotation of the radius, so in other words, supination and pronation, and you can see the way the tendons are getting caught in this tight gap, and this is impingement. So when I see patients like this patient here, you can see a very swollen, hypervascular, abnormal biceps brachii. Now, this patient had a sedentary job and hadn't had any trauma. So you think, why is this happening to this patient? And the answer is because of impingement. So when you put them through the dynamic test, as we put this dynamic test on, you can see the way that this tendon gets caught and it can't fit through that gap. And you can see the way that it gets jammed in there. And that's what's causing the patient to have impingement symptoms. So again, we have a very swollen biceps tendon here. You can see it coming down, and this is in the short axis. And now I'll turn into the long axis to show you how tendinopathic this tendon is. So it's quite swollen, and again, no history of trauma, no heavy work. So why is it swollen? And then when we do a dynamic assessment, you can see that between the radius and the ulna, there's simply no space, and it's getting caught in that gap there. And this is macerating and destroying the biceps brachii collagen until eventually we'll have a complete rupture. This patient I only scanned a couple of days ago, and very similar images, aren't they? It's swollen, it's hypervascular. Why is that the case? We do the dynamic testing. You can see some little longitudinal fissures and some little splits in the tendon itself, and quite a difficulty as it passes between the radius and the ulna there. There looks like there's a bit more space here, but it's still getting caught and it's still an impingement happening. The next thing I want to move to is the wrist, and I want to talk about another forgotten joint. So if the posterior subtalar joint is a forgotten joint, I also think the distal radioulnar joint is. So the first joint I assess in the wrist is this one, which is the radiocarpal joint. So it sits between the radius and the scaphoid, lunate and triquetrum. And you can see with the B mode and with colour Doppler how this is a very easy diagnosis of synovitis. But what I want to concentrate on is the distal radioulnar joint, which is this one here. So the distal radioulnar joint is really commonly affected by rheumatoid arthritis. Now, the way I assess the distal radioulnar joint, if you look at this top video, this is extensor digitorum communis, this is extensor compartment 4 of the wrist, and this is extensor compartment 5, extensor digiti minimi. Now, you may never have cared about extensor digiti minimi prior to this presentation, but after this presentation, it will become very important for you, because the gap between extensor digiti minimi and the hyaline cartilage of the ulna is exactly the thickness of the distal radioulnar joint capsule. And you can see in this case, it is grossly synovitic, and in fact there's an effusion as well. So what I look for is displacement of extensor digiti minimi away from the ulna. And then I put the colour Doppler in this space, and you can see this is synovitis. And this is how I find distal radioulnar joint synovitic cases. So these are the same technique, right? So this is the radius, and this is the ulna. There's extensor digiti minimi, and the gap between here and the hyaline cartilage of the ulna, this space here, is the thickness of the joint capsule, and it should be very thin. But here it's quite thick, and then when we use the Doppler, we can see it's vascular. So this is a patient, a classic patient that would have rheumatoid arthritis, and then they have synovitis of their distal radioulnar joint, and that is the reason that they've got wrist pain. So don't forget the distal radioulnar joint. I think it's really important. Another concept that I'm going to introduce to you is assessment of the thenar muscles. Now, these are the muscles at the base of the thumb, and there is many of them. This is the abductor pollicis muscle. This is on the most radial side. This is the first metacarpal bone here. This muscle here is opponens pollicis, the flexor pollicis longus tendon, the superficial and the deep heads of flexor hallucis brevis. This is the adductor pollicis that comes across and attaches to the third metacarpal shaft, and then this is the interosseous muscle. So this picture is quite powerful, and I'll explain to you why it's a powerful picture. And when I use it is when I'm assessing the ulnar nerve or the median nerve. So I take this picture for all cases of carpal tunnel, and of course all cases of cubital tunnel syndrome. So if we look at the anatomy here, this is the flexor pollicis longus tendon, and then we have the abductor pollicis, the opponens pollicis, and the superficial head of the flexor pollicis brevis. Now, all of these blue muscles are driven by the median nerve. Then we have the deep head of flexor pollicis brevis, the adductor pollicis that goes across to insert onto that third metacarpal, and the interosseous muscles. And these yellow muscles are all driven by the ulnar nerve. So because the thenar eminence divides so beautifully in half here, we can look for median nerve dysfunction here and ulnar nerve dysfunction here. So if we get atrophy here and preservation here, we have a patient with classic carpal tunnel syndrome. If we have atrophy here and preservation here, we have a patient with classic cubital tunnel syndrome of the ulnar nerve. So this is a nice case of carpal tunnel syndrome. So you can look how this nerve is really quite swollen, and then the nerve gets compressed as it goes down through the tunnel. So it's quite an easy diagnosis of carpal tunnel syndrome. And then when we look at the thenar eminence, the first thing I notice is how hard it is to see the flexor pollicis longus tendon. It's really like a chameleon here, because the muscles of the thenar eminence, the abductor pollicus, the opponens, and the superficial head of flexor pollicus brevis. These were the blue muscles. These are all atrophied away, and they're nearly as bright as the FPL. But the yellow muscles that are driven by the ulnar nerve are beautiful and black. So you can see here's another nice example where this is classic carpal tunnel syndrome, where all of the muscles on the radial side and superficial to flexor pollicus longus have atrophy, and the ones deep and to the ulnar side have preservation. This is the opposite pattern, where we have preservation of the components that are driven by the median nerve, but we have atrophy of the components driven by the ulnar nerve. So this is a person with cubital tunnel syndrome. And this is a comparison to the opposite hand, showing preservation of all muscle groups. Another thing that I notice in this part of the body around the thenar eminence is I have patients that present to me with a very tight, very tender, and quite swollen thenar eminence muscle group. And this is a really nice diagnosis. If you have a look at what happens here, they get first carpometacarpal joint osteoarthritis, and then they get synovitis of that joint. And then that inflammation spreads down the length of the first metacarpal shaft and involves the thenar muscles, making them echogenic and making them firm to touch and hypervascular. So this is a nice split screen comparison. This is the first metacarpal shaft here on the symptomatic side and the first metacarpal shaft on the asymptomatic side. And you can see how these muscles are more echogenic, and you've got all this inflammatory change sitting in here. If you then look with the Doppler, you'll see how vascular this echogenic area is. So it's a real inflammatory response and direct spread from that CMC joint arthritis. So it starts with classic first CMC joint arthritis, then you get the synovitis, and then you get the spread of the synovitis down the joint capsule along that first metacarpal shaft, and then it starts to cause some edema of those thenar muscles. I see this really commonly, and I think it's just a really nice diagnosis to make. You can see on the plain x-ray, the first CMC joint is osteoarthritic, and then you can see as you track down, you get this really echogenic band running all the way down that first metacarpal shaft. And when you do the split screen comparison, you can see this echogenic band is present on the symptomatic side, and it's absent on the asymptomatic side. The last thing I want to touch on is ECU, so extensor compartment 6, extensor carpi ulnaris tenosynovitis. It's a very easy diagnosis to make, but next time you make it, have a look at the ulnar styloid and look for any erosive process, because these erosions that we get in the ulnar styloid are a really early and really sensitive marker for rheumatoid arthritis, and they may also be associated with gout. So this is the same patient with an MRI, and you can see the erosion beautifully on the MRI. But what I'm going to urge you to do is to really have a look with the ultrasound. And next time you see ECU tenosynovitis like this, sure, make that diagnosis, but then look at the bone. And if you look at the ulnar styloid underneath this ECU here, you can see the erosion. And then when we go long axis on this one, you can really see that there is a clear erosion here. And this is a classic rheumatoid disease. So instead of just making a diagnosis of ECU tenosynovitis, let's make a diagnosis of that, plus get the patient to see a rheumatologist for a rheumatological workup, because that's what they really require. This is the same patient, and you can see this demineralization here of the ulnar styloid quite beautifully on the plain radiograph. Look, I hope you've enjoyed this presentation. Please stay in touch with me through my through my email address, stayintouch@birdultrasound.com.au, and please visit my website, birdultrasound.com.au, because on birdultrasound.com.au I have about 50 hours of beautiful presentations like this one for you to enjoy, and I hope you do enjoy them. Happy scanning, and bye for now.